All right, future doctors, namaste. Grab your chai, settle down. We're jumping straight into a topic you are going to see every single day in the wards: anti-epileptic drugs. I'm telling you, this is super high yield for your exams and for your practice. So pay close attention, okay?
So, what happens when the brain's electrical wiring short circuits? Just imagine, okay? Imagine the wiring in your house during a massive voltage surge. Everything starts flickering, goes completely haywire, right? Well, that's pretty much what a seizure is inside the brain. A massive, uncontrolled, chaotic electrical discharge. And to treat it, we first have to understand it. Simple.
Okay, so here's our battle plan for today. Super simple. First, we'll understand the enemy, the seizure itself. Then we meet our soldiers, the drugs. We'll get into their tactics, the mechanism of action. Then, the most important part, the part you need for your exams, matching the right drug to the right seizure. And finally, we'll cover the rules of engagement to keep our patients safe. Let's get started. All right, section 1, the brain's electrical storm. Look, before we can even talk about the fire extinguishers, we have to understand the fire, right? So what exactly is this electrical storm that's happening in the brain? Now, this is the first and probably the most important thing you need to get into your heads. These drugs, they are not a cure for epilepsy. Okay, we are not fixing the faulty wiring in the brain. We are simply managing the symptoms. Our job is to control and prevent these storms, to suppress the seizures, so the patient can live a normal, productive life. It's about control, not cure. Okay, now for the fun part. Let's meet the seizure stoppers, your core toolkit. These are the main players, the heavyweights in our medical arsenal. Think of these as your go-to weapons against different kinds of seizures. First up, we have carbamazepine. You need to know this one. It's a real workhorse, the first-line choice for partial seizures and what we call GTCS. So that's for your simple partial and complex partial seizures, SPS and CPS, and also for generalized tonic-clonic seizures. It's one of your main go-to drugs. Super reliable, very effective. Next, we have valproic acid. This one is the broad-spectrum all-rounder. Now look, if carbamazepine is like a sniper rifle, very precise for a few specific targets, then valproate is the heavy machine gun. It's got a huge spectrum of activity. It takes care of so many different seizure types: partial, GTCS, absence, myoclonic, you name it. It's an incredibly versatile and powerful tool to have. And finally, in this group, meet ethosuximide. This one is a total specialist. It's not a machine gun. It's more like a very specific key for a very specific lock. Its main job, really its only major job, is to treat absent seizures. Those brief zoning out episodes you often see in kids. For that one specific job, ethosuximide is the expert. All right, everyone, listen up. This is the mechanism masterclass. This is the part that's going to get you those extra marks in your Pharmacology Viva. Understanding how these drugs actually work, that's what separates a thinking clinician from just a blind prescriber. So focus. Okay, so let's break this down step by step. Step 1. In a seizure, you have a neuron that's just firing repeatedly way too fast. Step 2. Our drug, let's say carbamazepine, comes along and it binds to the sodium channel of that neuron. Now here's the clever part, step 3. It doesn't just block the channel, it prolongs the channel's inactivated state. It's basically telling the neuron, hey, you need to take a longer break between firing. And the result? Step 4. The neuron simply cannot fire as rapidly, and that calms the storm. So you can basically think of two main strategies. On one hand, you're blocking the excitation. That's carbamazepine's main job. It prolongs that sodium channel inactivation we just talked about. But then you have a drug like valproic acid, which is a multitasker. It does that too, but it also enhances inhibition. It boosts GABA, which is the brain's main calm-down signal. So it's not just blocking the go signal, it's also turning up the stop signal. A very powerful combination. Okay, everyone, phones out. If there is one slide you are going to screenshot from this whole thing to memorize, to write on a sticky note for your exams, it's this next one. This is the clinician's cheat sheet, the practical, what do I actually do part. Okay, look at this table. For partial seizures, SPS and CPS, what do you see? Carbamazepine, valproate. First line. For GTCS, same story. Valproate, carbamazepine. But now look at absence seizures. This is where it changes. Your first line is valproate and ethosuximide, our specialist. And for myoclonic seizures, valproate is the clear winner. You have to know this table. It is pure gold for your exams. And listen to me very carefully now. This is a classic trap, a mistake that students and even junior doctors make. Using carbamazepine for absence seizures. It's a huge mistake. It can actually make them worse. Remember this for your practicals, for your exams, for your patients. This is a massive clinical pearl. Do not forget it. All right. No drug is a magic bullet, okay? With all this power comes responsibility, and that means you have to know the adverse effects and interactions. We have to handle these with care. This is all about keeping the patient safe. Okay, another very, very high-yield concept for you. Think of the liver enzymes like a factory assembly line that breaks down drugs. Now, carbamazepine is a potent enzyme inducer. It's like hitting the fast-forward button on that assembly line. It chews up other drugs faster, making them less effective. On the other hand, valproic acid is an enzyme inhibitor. It's like hitting the slow-mo button. It slows down the breakdown of other drugs, causing their levels to rise, sometimes to toxic levels. Inducer versus inhibitor. You must know the difference. Now, with valproate, there is one major concern that we have to talk about separately, and that is pregnancy. Let me be absolutely clear. Valproate is a known teratogen. That means it can cause birth defects. Specifically, there's a serious risk of neural tube defects, like spina bifida. This is why you must be extremely, extremely cautious when even thinking about prescribing it to women of childbearing age. And if you thought that was bad, look at this. The combination of valproate and carbamazepine. It literally doubles the teratogenic frequency. It doubles the risk of abnormalities. This is a stark reminder of just how careful we have to be, especially with these patients. Okay, we're almost at the end. Let's wrap this all up with a few key principles for practice. This is the professor's final word, so listen carefully. Just remember these core treatment rules. Rule number 1, start with a single drug. Monotherapy is always the goal. Rule 2, increase the dose gradually. Start low, go slow. Rule 3, and this one could save a life. If you're withdrawing a drug, you always do it slowly, never stop abruptly. Why? Because you can trigger status epilepticus, nonstop seizures. It's a medical emergency. And rule 4, in pregnancy, seizures are also dangerous, so you often have to continue therapy, but with extreme caution and careful drug selection. So I just want to leave you with this final thought. Remember, our goal here is not just to stop seizures. It's to give the patient a life. We are not just treating a brain scan or an EEG report. We are treating a person. Someone who wants to go to school, get a job, have a family. So you must always balance the drug's power with the patient's well-being. Find that balance so they can live their life to the fullest. Thank you.